Welcome everyone to the Aurora Health Alliance and Mile High Health Alliance webinar series focused on eConsults. My name is Mandy Ashley. I'm the Executive Director of Aurora Health Alliance. We have a tight schedule today, and our next two events are the next two Wednesdays at the same time, 12 p.m. So we hope you can join us then as well. Few housekeeping things. Please keep yourself on mute because we live in this Zoom world. And if you have questions for any of the presenters, or if you want to continue the conversation, please type those into the chat. After each of our presenters, we will have time available for questions for them. So I want to introduce you to Vicente Cardona, and he can introduce himself and our speakers. Thanks.
Yes, thank you, Mandy. And again, my name is Vicente Cardona. I'm from Mile High Health Alliance, and I'm very excited for today. We get to collaborate with so many different people. I also just want to say thank you all for joining us today to talk about eConsult. And like Mandy said, we have a very busy schedule, so we'll try to keep this pretty short. But I also, lastly, just want to say thank you to all our speakers for taking the time to present. So just a little bit of a rundown for today for the agenda. We'll begin the web series with Adiran Okol-Oko from Colorado Health Institute, presenting more of a level-setting overview of what is an eConsult and highlighting a statewide model for increasing access to specialty care. Then we will have Beth Newholfen to talk about Project Core and highlight work being done outside of Colorado. And lastly, we'll end the webinar with Chris Cruttenden presenting his works and findings with their eConsult platform in California. We all hope that you enjoy this, and if I had a mic, I would hand it over. I'm just gonna hand over the virtual mic to Adiran. So thank you again.
I also forgot to mention that speakers, I'm controlling your slides. So if you need to advance, just let me know.
Perfect. Well, thank you both for the introduction. Again, I'm really thrilled to be here virtually with all of you guys. My name is Adiran Okol-Oko. I'm a program manager with the Colorado Health Institute, where as part of my work, I support the Ascent cohort pilot program. And that cohort, Vicente belongs to, is a part of the Mile High Health Alliance. And it aims to increase specialty care access for underinsured and uninsured adults. So as a part of that work, the cohort focuses on increasing access by way of both face-to-face referrals and eConsults. So I'm really happy to be here today to share a little bit about the potential of eConsults with you. You can advance the slide, and again. Great. So let's get started. Today we'll begin by outlining part of the issue of specialty care access in Colorado, though I'm sure I'll be preaching to the choir on this call. Next, I will define eConsults and explore their potential as a possible solution. And then we will finish by introducing a proposed statewide model for increasing access to specialty care. Next slide. So what is the issue here? Well, we know that Medicaid enrollees and people without insurance use specialty care at lower rates. The median time that Coloradans wait for a general doctor's appointment is 2 days, but it's important to consider the layers that are incorporated, sometimes by a single asterisk. 2 days for a general appointment, but it's more than 9 days for specialist care. And some Coloradans report waiting up to a full year. Then when you layer onto these figures the impact of insurance status, the unmet need is even more striking. Medicaid enrollees report waiting 1.4 times longer than commercially insured patients to get specialty care. Furthermore, finding a provider to even get to that step is even difficult. Medicaid enrollees are nearly 3 times more likely than commercially insured patients to report they didn't get specialty care because they simply couldn't find a provider who would accept their Medicaid insurance. And all of this ultimately results in 13% of Medicaid and CHIP enrollees and nearly 30% of uninsured Coloradans who simply do not see a specialist at all. Next slide. So what is an eConsult? I think if you can keep clicking and it should pull, yeah, perfect. What is an eConsult? One way we can begin to think about the unmet need is through this very simple framework that you see at the bottom of your screen. So on one end of the continuum, you've got approaches that connect patients directly to specialists. These are your classic in-person referrals. So a patient presents with an issue at their primary care physician's office, and that PCP refers them to the cardiologist whose office is located elsewhere, right? Ideally, the patient goes to that in-person appointment with the cardiologist to address their health need. We also hear more and more about certain specialty services being provided remotely via telemedicine in both urban and rural areas. I'm sure many of us have gotten more comfortable with this form of care during COVID times. I know I have. And then on the other end of this continuum, you've got some more upstream approaches like Project Echo, which trains PCPs to address specialty care needs in a PCP setting, as well as eConsults, which of course is the focus for today, that support primary care physicians to practice at the top of their scope and helps to prevent a logjam of unnecessary referrals. So what I really want you to take away is there are multiple different entry points to improving access to specialty care that don't all require increased face time with specialists. And eConsults are a great example of this. This graphic is pretty simple, but I think it shows at a base level what they are. The PCP requests a consult and sends all of the relevant patient information over to the specialist. So this could include a description of the presenting issue, any important medical history, things like that. And then this gets reviewed and responded to by a specialist. So essentially, an eConsult is digital communication between a general healthcare professional and a specialist to get specialty care advice without a face-to-face patient encounter. And eConsults are critical tools for addressing specialty care needs because they don't require a patient to schedule, figure out transportation to, or pay for a face-to-face visit with a specialist. Next slide. Yeah, you can just click through. Yep, perfect. So how big of an impact could eConsults make? CHI conducted an analysis last year, overlaying several different data sources to begin to quantify the unmet need for specialty care, particularly for uninsured and Medicaid patients. So for adults between the ages of 19 and 64, close to 635,000 specialty care visits go unmet every year. That's about 83 extra visits annually for each of the state's more than 7,000 medical specialists. When we further drilled down into those unmet visits to examine what they were for and whether any of them could have instead been addressed by way of an eConsult based on expertise and literature that was reviewed, we see that about a quarter of Colorado's unmet specialty care visits could have been avoided if an eConsult was used instead of a referral for a face-to-face visit. Next slide. You can click through, perfect. So some specialty areas do lend themselves to eConsults better than others. For example, the literature suggests that almost half of neurology visits can be addressed with an online or phone consultation between primary care provider and specialists. The literature that CHI reviewed to identify studies was showing that avoided specialty care visits can be avoided as a result of an eConsult. And this table shows across those 15 studies or so that were reviewed, what specific specialties could see the highest reduction in unmet visits and associated improved access by way of eConsults. So if you look at this table, that third column there, where it says portion of visits potentially avoided by eConsults, those are all figures that came by way of the literature review that was conducted. And then those numbers on the fourth column there are addressing or applying those percentages to Colorado's specific population and the visits that we saw. So for example, for dermatology, we saw that maybe 40% of unmet visits could have been addressed by eConsults, which equates to 37,000 visits that were unmet. Next slide. So I just want to leave you with how CHI thinks about what a future system model could look like. The statewide specialty care system that we envision does include eConsults. It also includes telehealth and in-person visits. But it also requires investment in systems transformation to fundamentally change the way people access care. So this includes things like providing education to promote specialty care access in primary care and non-traditional environments. It also includes increased use of advanced practice providers such as NPs and physician assistants, and then emerging innovations such as machine learning that can increase access to specialty care. So Colorado will need both short-term and long-term options to launch this model and then ultimately sustain it. Some of the short-term financing options include establishing social impact bonds where funders provide capital and then the state pays them back when program outcomes are achieved. And we could also leverage hospitals' community benefit programs as they promote community health while helping health systems retain their tax exemptions. Then when you think longer term, we would need to change Medicaid and reimbursement to recognize specialty care consultations delivered via that eConsult model and expand loan repayment initiatives, because those could serve as a great incentive for specialists to practice at really high need sites. So I know that we have a really packed agenda. You can advance the slide. Just wanted to lastly make sure that I share with you all how you can read more about the work and details behind this analysis. So the full report is available for download on our website. If you go to coloradohealthinstitute.org and you type in specialty care, a number of reports would pop up, but this is one of them, and that is how you can read the full report in all of its detail. And then one more slide. And then you can see here at the bottom, you also have my email address and my direct line if you have any questions about any of this. But I know that we have a tight agenda, so I'm going to hand it back to Mandy and Vicente.
Thanks, Adiran. Do you mind if we include your contact information when we send communication back out to people who registered?
Yes, of course.
Okay, thanks. Vicente, do we have any questions that rolled in?
Yes. So one person asked, because they were talking about, there was a bullet point noting that the upstream intervention included leveraging machine learning to synthesize knowledge. What does that look like and how can it be implemented?
So this comes from a few different examples that I believe were identified in the literature. And I know that, I believe Alex is on the line as well, who was directly involved in the report. So correct me if I'm wrong and keep me honest, Alex. But an example of that is the Human Diagnosis Project. And that is something that synthesized knowledge globally from hundreds of different volunteer specialty care providers to get smarter, essentially, about how this care is being delivered. Alex, anything you would add on that?
Adiran, perfect. I just dropped the link into the chat. I also dropped Adiran's email and the link to the report. And I recognize a lot of names here. I think some of this group has seen the report before, so some of that might be familiar. But I also wonder if anybody's had experience using the Human Diagnosis Project. Is that familiar to anyone? Because I have not. We just know a little bit about it. So good question.
All right, and if there's no other kind of response, there's one more question that we have. I think on one of the slides, there's a statistic stating that 13% of Medicaid patients and 30% of uninsured patients do not see specialists. How does this compare to the privately insured population?
I believe the private insured population is around 9%. I have to double check and confirm that with our data, but that comes from a survey that CHI puts out.
Awesome. Well, if there's any other questions that you guys may have for Adiran, please leave it in the chat. Even if it's a little late, we can send her some questions and then we could get back to you with a response. I'll just wait a couple minutes and then we'll move on to our next presenter.
Oh, hi everyone. This is Beth Newhalfen, and I'm just going to give you a quick national perspective. I'm not going to go deep. Next week I'll go a lot deeper when I talk about Denver Health, but I work at Denver Health. I'm the Associate Director of Quality and Operations, and I also am faculty for the American College of Physicians for the last 3 years. So a lot of this national perspective comes from American College of Physicians. We did a pilot for high value care coordination, which is the medical neighborhood, and eConsults always came up. I mean, depending on where people were in their trajectory of a medical neighborhood, I mean, typically doesn't come till later. It's just like when patient-centered medical homes came about in Colorado in 2008, 2009. I was part of the first 16 patient-centered medical homes in Colorado, and, you know, that was a newer concept then. Now, you know, it's a regular household type medical home name. So eConsults, where it may be new to some of you, it's actually been around a while. You can go to the next slide, Mandy. Thank you. So, you know, the AMC Project Core, I want to go over that real quick. AMC is the Association of American Medical Colleges. So in 2014, they received an Innovation Award, which enabled them to launch this Project Core, which is really, CORE stands for Coordinating Optimal Referral Experiences. So it kind of, you know, a little bit of the slow start, started with just a few academic medical centers, and, you know, they were able to launch this and pilot it, and then it gained steam over the years. And so it was originally piloted at UCSF Medical Center, and the tool aims to enable more effective communication and coordination, just like CHI just said, what a definition of an eConsult is, between primary care and specialists, while improving the quality, the access, the patient and the provider experience. I mean, when people go after these eConsults, typically they're looking on a national perspective, it's really more what they're trying to get out of it. So, you know, a lot of safety nets, a lot of academic medical centers are looking at the access, especially in big cities, rural areas, but sometimes they're just looking for better quality of care for patients, keeping healthcare costs down for patients, and just the healthcare experience overall. So when I talk to people around the country, their reason for getting into eConsults really varies amongst what their main aim is. And all of them usually are interested in the patient-provider experience as well. So now the AMC Project Core has worked with over 35 academic medical centers in 20 states to implement this program. And the model is utilizes specialty and condition-specific templates to enable these focused clinical exchanges between providers. So some of them are down to like a diabetes type condition, and those eConsults go toward more condition. Otherwise, they are just, you know, for many specialties overall, the eConsults can be submitted. And in this Project Core, it's more voluntary. So it's not like 100% of referrals are eConsults. It's really up to the referring clinician. Do I want to send a regular referral, or do I want to send an eConsult? And so it is voluntary, although it takes training over time. Anyone that has instituted eConsults, is really this training between specialists, providers, the unknown, getting comfortable, you know, trying to do something new with patients. And so it takes a while usually to get going on things like this. The model utilizes the eConsults, and usually it's a single exchange, meaning like the clinician will send an eConsult and they'll get back that expert advice from the specialist. Occasionally there's the back and forth more than once. For the most part, most of these are just a single exchange. And the expectation is that they respond within 72 hours, but most are closer to 24 hours or less, so that's great. If the specialist deems the eConsult question to be too complex, the eConsult is typically declined in this model and recommended for an in-person consult, and whereas the clinician would then need to put in a referral, a regular referral for face-to-face. Next slide. So, so the academic medical centers have committed up till about 2019, most of them were providing incentive RVU credit or payment themselves, really taking this on without payment for the most part. Prior to that, the payments were kind of self-funded, and so they needed to be bigger centers, right? Not a small specialist office. Typically, they're big institutions that can take on the payment for this and just kind of absorb this because they're so interested in access or this quality of care. However, with the approval of the interprofessional internet consultation codes, and I could go on and on about payment, but I'm not going to today. I'm just going to highlight, you know, these new codes that CMS put out, CPT codes 99451 and 99452 in the 2019 Medicare physician fee schedule. Now the 2020 physician fee schedule has come out. A growing number of centers are actually now billing Medicare for this service, as well as engaging regional commercial payers and state Medicaid, you know, plans to provide reimbursement for this service. You know, there's been back and forth. I expect there'll be changes in the future. A lot of payment right now is structured around patient permission and sign off to do this kind of referral, even though their primary care clinician is making the decision. Some of these payment models are really, the patient has to say, okay, I agree to that. You're just going to talk. You providers are going to talk amongst yourselves and decide the best plan of care for me, and I won't even be involved till you're done talking, kind of thing. So I expect some of those regulations to change throughout time, and documentation, things like that. Same with telehealth. But across the 10 core medical specialties, the most common ones you see nationally are probably more medicine-based versus surgical-based. eConsults accounted for 8.8% of all specialty contacts, so eConsults or eConsults plus referrals. So quite a bit. A lot of these people are using eConsults. And for every specialty visit averted, now this is through Project Core, an eConsult is estimated to save patients approximately $100. And if you take into account the avoided copays, the transportation costs, the missed work, things like that. So, you know, add that up over thousands of patients, it's quite a bit of money. And in a survey, and this is, I think we expected this, but it really capitalizes on how patient-friendly and provider-friendly this is. In a national survey, 81% of patients were satisfied with the specialist eConsult. So recommendations, they felt comfortable. They felt like their providers, their clinician team was in cohort with each other. And 95% of patients felt like the specialist advice was conveyed promptly and clearly. So they understood the plan of care, whether that was to, you know, stay with the PCP and manage that condition or what they were being sent for, or that, you know, that the clinicians decided, hey, this would be better for them to come in face to face. So, but they felt like that was conveyed clearly to them afterwards. So that was good news. Next slide, Mandy. Thank you. So other models that are around the country. Now I don't want to take any steam off the next presentation, but there's other, you know, Safetynet hospitals in California that have a model where all referrals, inquiries to specialists are sent as eConsults. It's not a pick and choose as Project Core is. And the specialist then determines if he or she will respond by eConsult or schedule the patient to be seen in person. So all referrals are actually eConsults and decided. Emory Grady is one example in Georgia that have rolled out eConsults through their EHR. They start, you know, when I started working with them, they said, well, let's just do them all. You know, let's do everyone. And I said, well, usually that's a little overwhelming for a system. Pick your number one specialty that you just have a lot of volume. You have the providers saying, you know, I see a lot of people that I don't really need to see. If I had an image, if I had something I could see those people fairly fast, you know, just online. I wouldn't really need to have an actual face-to-face visit. And so they started with dermatology, excellent results, avoided 80% of their dermatology referrals, inappropriate referrals that really didn't need to be seen face-to-face. And then they moved on to renal because that was their next point of access issues. And then they're starting endocrinology at the beginning of September because that was their third. So they're slowly rolling practices, rolling providers on, and many other groups are using their own EHRs to develop a voluntary eConsult platform. Like Epic is probably the major one. Brown Medicine is doing that as well. In Connecticut, they're doing that using their own EHR to, that where providers have options. They can put in a face-to-face referral, a regular referral. They can put it in an eConsult. I've seen some places, neurology is a big one where so many referrals are sent for headaches. And it's really overwhelming. So the neurologists really want to see, the scans that have been done, and they want to have all people that are sent for headaches as an eConsult. So it really varies across what people are doing. I think, what I've seen from the perspective of nationally is that people want to play in this sandbox, but they're not completely willing as an institution to go full in if it's not reimbursed at the state level. I mean, and CMS has come on, but they really need commercial payers and Medicaid to come on board as well if they're going to jump in and allocate that much time for providers to increase access. And some of the AMCs and larger institutions are developing ways to work with smaller practices to engage them in eConsults within the neighborhood. So not just one big system and center where you have primary care and specialty in the big system like Yale, but you have your smaller practices that often refer to specialty and giving them an opportunity to have a platform for eConsults as well. Next slide. I think that's it. If anyone has any questions, I'm happy to answer.
Cynthia, have any come in?
Yes, one question, at least that I had, is for the conditional specific templates that you talked about, do they only focus on specific diagnoses, or do they kind of cater to a specific specialty?
They're typically to a specific specialty. I mean, I have seen it where it's a diagnosis, diabetes, hypertension, something like, or the headaches. Like I said, out of all neurology, they only want to have eConsults for headaches. But overall, it's really the specialty that I see that they go for, the overall specialty, like dermatology, where, hey, take a picture, send in your question, your clinical question. I mean, it's very important with eConsults. What I see people put them together, that there's an actual clinical question. What kind of question are you trying to get answered from the specialist? And so it's really about the clinic itself that I see. And like I said, mostly medicine. I mean, it goes into some surgical specialties, but medicine is probably the number one, the top 10.
Awesome. Another question came in is, which specialties are receiving the most eConsult in the Project Core model?
Let me get to that. I have that, and it's probably what you would assume. That would be, it's dermatology. It's sorry, I'm scrolling down here too, so I can give you the absolute final answer. It's allergy and immunology, cardiology, endocrinology, GI, hepatology, hematology, infectious disease, nephrology, neurology, pulmonology, rheumatology. So like I said, primarily medicine type specialties.
All right, we'll make sure to, I'll ask you later to get all those down and we can send them to the group. And,
I'll try to memorize those.
Yeah, and then a last question that I had, and I know you said that you didn't really want to go into too much detail on the reimbursement, but someone asked about the reimbursement for those two CPT codes that you listed on your slide.
Okay, and what's the, What's the question?
What is the reimbursement rate for
Oh,
the
what is the reimbursement?
Yes.
It varies. It really varies based on contracts, if you're FQ, if you're not. So I don't, you know, it really varies on what those reimbursements. They can be around $80. They can be up to $120. It really depends. And I mean, it's less than typically a visit, but also it doesn't take as much time as a face-to-face visit. And what's great is providers aren't losing time for no-shows and things like that that are really, you know, if any consult is really between providers, so they're not losing patient time.
Awesome. Well,
I can try to find that out.
Okay, great. I'll put that in my notes. And then, Mandy, do we have time for one more question?
Sure. Yeah, we're doing great.
Okay, great. So one question was, for uninsured, there is no reimbursement. Nationally, there is an eConsult. Hold on. There is, nationally, is that eConsult gap in access to specialty care being addressed somehow?
Yeah, some of the medical centers around the country, I'd say more that are they're using their own EHR platform, are looking at the no insurance, and you know, a lot of those places, well, like Denver Health, that absorb a lot of those costs are looking at, you know, the cost of a face-to-face or a no-show versus you know, an eConsult, and time saved, you know, or money loss is less. And so they're looking at how can they wrap that in a model where, say, they have, you know, they get paid so much for absorbing these kind of patients that have no insurance. What is that worth to the system, and how can they get? It's always like, how can we get more providers to accept patients that don't have insurance, or patients that you know, refugee populations, things like that. How can we incentivize specialists to take on more of that? And this is one of those ways that I've seen. Emory Grady is a good example of how they take on that kind of, they're new in this, but how they're already looking at how they can take that on into a model. Hopefully that answered the question.
Thank you, Beth. I appreciate that. And I think the person who sent the question also appreciates that as well. Again, guys, if you have any additional questions for Beth, feel free to put that in the chat, and I'll make sure that she gets those questions. If there's no other further questions, we will move forward with our next presenter. And Chris, I will let you take over.
As well as another model that we've been working on in a couple places. So creating health equity through better access. Next slide, please. So just a quick information about us. Safetynet Connect, Net Chemistry owns them, is an eConsult solution. We're the only asynchronous enterprise multi-tenant platform. And what that means is we're a collaborative platform where we'll have a couple county healthcare systems, a Medicaid plan on their community clinics. We have different groups that have vertical networks that can manage their patients on our system. We've completed more than 1.3 million successful consults to date for 40 customers. A majority of those consults were done in these multi-stakeholder collaboratives. Our service area covers over 10 million Medicaid, low-income, underserved, uninsured patients. We have engaged thousands of primary care and specialty providers and implemented this enterprise solution for the second and third largest Medicaid systems. And now we're in Inland Empire, which I'd probably say is the fourth largest Medicaid system in the country. Next slide. A little overview of what it looks like in some of our clients and our markets. We have over 1,000 organizations within our systems, 10,000 plus providers, obviously over 1 million consults, 10 million plus patients. We are across the country. We also work with other groups and put them in the business of eConsults. We have other people ask for our platform and then they run with it and bring their specialists to it. We're additionally working in Colorado with Kaiser at this time. Additionally, with that Kaiser implementation, we're working currently with Clinica Family, Clinica Tepeyac, Hope Light, Inner City Health Center, which is affiliated with Mile High, Mission Medical, Mountain Family, Salute Family, Stride, Summit Community, and the Summit Specialists currently in Colorado. A few of our clients, clients are LA Care, Cal Optima, Inland Empire, mostly Medicaid, Riverside Health System, and we are working within public plans, correctional, community health, as well as commercial. So we do cover the gambit. Next slide, please. So we all know it works, but SNC's eConsult solution, our model is to unlock the untapped asynchronous capacity of specialists across your state, across your county, across your region. So that's why we go with these multi-collaborative structures. Next slide. And distribute that unlocked capacity to disparate PCPs, community clinics, hospitals, and post-acute care. So an example of this is an Orange County example. We have all the hospitals connected. We have the community clinics. We have specialty networks connected, specialists even from some of the hospitals. And they all converge, as we like to call the product, into one single platform. But every plan or collaborative has their own direct network that they can manage their policies, how they like to do eConsult, and not have to worry about how somebody else does it, but they can leverage the layer of specialists across the top throughout the whole community. Next slide, please. So just some fun facts. Everybody's kind of doing this out in the community, but one of the keys that we believe to making eConsult successful is bringing in the eligibility for Medicaid. In California, we bring in all the Medi-Cal. In Cook County, we bring in Medicaid in the state of Illinois. We do ADT creation, so any new patients created is automatically added and created in the system. Minimally, we like to do a single sign-on. If we can do a deeper integration, order results, or once a console is completed, we send it back into the EMR. And then we also allow, in a lot of situations, where we'll do an 837 and submit the claim on behalf of the provider. Next slide. So how does our system work? It's very similar to what you've heard today. PCP sends a secure request via console. Takes anywhere from seconds to minutes, and a specialist answer it. One of the things on the PCP side that we've done is we have pre-consult recommendations. We refer to them as best practice clarifying questions. Whenever you implement an eConsult system, I actually like just to create the dialogue between the PCP and the specialists for the first few months to 6 months, and then you start to bring in best practices, because you'll start to see a trend where you don't want to get the same question that they should be answering ahead of time versus having a specialist answer that. All patient information is to be successful is included, usually through the eligibility system, as well as because we have the eligibility feed, we know they're an approved patient and they're currently eligible at that moment for a specialty consult, but also if it turns into a referral. We'd like to help incentivize managing that patient in the medical home as much as possible. And as we saw earlier in the other slides, reduce unnecessary travel for the patient. For the specialist, providing clinical guidance and asking follow-up questions, we really believe in a dialogue. We need the PCPs and specialists to communicate. The specialists need to educate that PCP on how to best manage that patient issue. But what happens is there's an evolution within eConsult. When you have a dialogue, the PCPs learn how to ask better questions, create better consults, and all of a sudden you see this evolution of, you're not seeing these common questions anymore. You're really seeing good cases, co-management, and oftentimes they won't even ask the specialists on some of these questions because they've learned through the process. We are seeing a lot of co-management, especially in behavioral health, where the specialist will help or a psychiatrist will help with the patient in the medical home. And when you do a referral, as within all cases, they're really great referrals because you've done the pre-tests, you've done the workups, you eliminate any unnecessary travel. So if it does turn into a face-to-face referral or a video referral, all the pieces that are necessary for a good visit are completed. So usually you have one visit versus 2 or 3. And we've seen this, especially in ophthalmology, where it used to be 2 to 3 visits, getting the retinopathy and all that. And now it's usually all that's completed and it's 1 visit for the specialist. Next slide, please. So in our system, and as pretty similar with what you saw earlier today, and probably if you do some research, 54% reduction in inappropriate referrals. We do a lot of consults. Just in LA alone, 20,000 a month, and that's including consults, and some of them turn into referrals after the fact. I think in Inland Empire, we're almost up to 10,000 consults a month as well. We see a 68% reduction in patients with co-managed in their medical home. I'm sorry, so the 68% of those patients can be managed in their medical home through the specialist and the PCP management, which is really, really nice, especially in these rural situations that we have in outer LA and outer Riverside. And then this isn't for all specialties, but for ophthalmology and a few others, the wait times are reduced dramatically by 89%. LA is an amazing case study, just like we heard earlier, especially access for GI and ophthalmology and a few others were literally a year wait. And once they implemented eConsult, 2 days to access as far as communication with a specialist. And now everything's a best practice. It's literally scheduled according to when they need to see them versus when they can get them in. And one of the scenarios that we always like to refer to, even with video, a specialist can see 12 patients in the course of 8 hours, maybe a couple more, video, maybe a few more if you have really efficient meeting setup. But on average, when specialists get really comfortable with the eConsult system, they're doing 12, 14, 15 consults in an hour. And that efficiency just exponentially grows your capacity, especially if you have specialists across the state who may have some downtime, who can answer some of these questions and help co-manage and reduce unnecessary specialty referrals. And these data was from a published report in JAMA by Lauren Daskovich. Next slide, please. So as we heard earlier today, and if you just do a cursory look, cardiology consults with Medicaid patients result in lower means of cost per patient. Ottawa-based, Canadian, $11 per consult savings. DHS found that 25% of eConsults resolved without the need for a follow-up visit. In health affairs, eConsult Medicaid patients and 4 specialties result in average savings of 84. We've seen savings from 84 to 300 across the different communities, just depending on impact and efficiencies of how they're using the eConsult system. Next slide, please. So as we heard, patients like it, and the patient impact is an interesting piece. We've done surveys and 85% is pretty good, but we've actually even seen them higher, like 95%. They love not traveling. They love knowing that the doctors are communicating on their behalf, which they probably thought was happening before, but now it's actually happening. Fewer days off work, more care received. They like being in their medical home and not having to go somewhere else that they're not as comfortable with. It's also interesting too, because once the patient knows that the PCP and specialist talking about them in this consult, they're more likely to show up for the specialty visit. They also love the fact that when they do see the specialist, they're informed, as opposed to a lot of times what we used to see, the patient would show up at the specialist office and they're like, well, what's going on? And fewer specialty visits required, treatment plan. Next slide. So primary care is an interesting one. When primary care physicians start using it, especially in some areas where they are located and have more trouble getting access to specialists, they really enjoy it. Obviously, asking a primary care physician to do one more thing is a lot, because they're already doing a ton of stuff, and we do hear that grumbling. The interesting thing is, the more grumbly the PCP is about using eConsult, the more they're your advocate about 2 or 3 months down the road. We had, who's now in charge of LA Care, Dr. Seidman, literally threw us out of his clinic saying, I'm not doing one more thing. And then he started speaking on our behalf at all these events specific to eConsult, because he loved it so much and he couldn't believe how much it was helping and how much it was creating efficiencies within his practice. So you do see improved care coordination, better scheduling, opportunities to enhance clinical capability. You're educating the physician, co-management. There's so many benefits to it. And actually you do create efficiencies where you don't have to do as many referrals. You can care for that patient sooner and quicker. On the specialist side, extending their expertise, reduced wait times, face-to-face visits are more productive. Pre-visit testing is completed, which is just huge, as opposed to sending that poor patient to the specialist who says, well, I can't do anything until you do the test. The triage for avoidance of inappropriate referrals, teach, educate the PCP. And they really do, like, once you do eConsult for about a year in a really efficient system, you start to get really great cases, which is, it's kind of interesting, but they really like to see what starts to come over the board, as opposed to like neurology. I have a patient who's dizzy and they're like, well, that's benign vertigo, do the Epley maneuver. I don't need to see that patient. And then all of a sudden it really turns into, you know, some interesting cases. Next slide, please. So keys to success, we're a little aggressive in our keys to success, and it's, you know, it is reaching, but I do think it's important. Workflow and review and redesign, really understanding what's going on, whether it's the health community, even the clinic level, how are they doing referrals now, and trying to integrate the eConsult process within that workflow, or helping to redesign it where it creates as little disruption as possible for that clinic. I do believe in incentive payments. We've done both. We've implemented without them, and it was successful. The ones where we implemented and provided a small stipend for PCPs to get on board with it, and not for the whole time, also creates a lot of success. Reimbursement for specialists, automated A37 submission is great to help coordinate that reimbursement. Minimally a basic single sign-on. And then you can't just deploy it and leave. You have to do ongoing process improvements. So you really have to check in 3 months, look how everybody's asked questions, what's not working for them, 6 months and a year. And then you can actually just look at reports and start to work on the issues that arise. You do need unified, so you need a leader that says, hey, we're gonna do it. You do need quality assurance reviews. You have to look at the eConsults that are coming over and make sure that they're good, because it gets really frustrated when a PCP asks a very great question and the specialist says, yeah, or no, or just send them to me. And there's no education, there's no dialogue, there's no helping the patient in those types of situations. We also do integrated authorization approvals, which really lends to some of these clinics. When it does turn into a referral, they don't have to go and wait. I just did a consult, now I have to wait 45 days for the approval, because the consult is connected with the auth and the specialist says I need to see them. Usually they're approved right then and there, and that also streamlines the referral process. And this is a biggie, and this is impossible in all situations, but making eConsults mandatory prior to the physical referrals. We do that in LA, we do that in Inland Empire, we do that in Cook County. And there's always a little pushback, but it's amazing how quickly that pushback fades when the auth process is streamlined. So you have to do both. You can't make it mandatory and then have a horrible auth process. But if you make it mandatory and the specialist deems that it's a face-to-face visit, and that is a trigger for approval and auth, all of a sudden the pushback goes away and people really do appreciate the efficiencies that are gained from this process. Next slide, please. So the opportunity for the state health system, my vision would be to do a statewide for Medicaid and bring on the different RAs to help manage their own networks or their own regions on one single system. So you can manage your patient population, even your own specialists, but then augment with specialists that are available across the state. So lower mean specialty visit cost per patient, if you deployed it. On average, we would see a 25% of eConsults were resolved without the need for follow-up, and that's being very conservative. We'd see a decrease in unnecessary special referrals by 50%. That's also being conservative. You'd actually see probably better. Not all specialties are equal. You see 175, a little more or a little less, depending on certain regions, average savings per patient. Better quality of care for the patient, integrated authorizations with plan providers is the opportunity to deploy a system state down. And the keys to that state down is you're not forcing with a system like ours, which is a collaborative, you're not forcing everybody to be the same. All the regions, depending on their specialties, their patient makeup, you can have your own specialists that are in your own policies, and everything is very specific to what your region needs. That's the key. And also manage your own providers and manage all the pieces to it autonomously without having to worry about, working with the other group that has something a little different going on. But you can still share specialists across stuff. All right, next slide. So one of the things that we see also, we keep running into hospital and health systems, and they're like, well, hey, we've got our integrated Epic EMR consult system, which is okay. Cerner doesn't really have anything that great right now. And they're like, well, we don't need it. And I say, if you're really successful and you're great doing it, but what about the outside community clinics that you're trying to service? What about patients that really need to be referred into your health system? So we actually, within Riverside University in Riverside, REHS, we have that type of model. We have that type of model with Keck at USC, where they actually have extended their specialty academic network out to the community, pretty far out to the community, and they add advice, and then when they see a case that really is a complicated case, they get referred into the medical system there. So eConsults not only serve as the umbilical cord between community clinics and hospitals and physicians, but establishes a connection with the patient to enhance the quality of special referrals. A lot of these community clinics aren't on the Epic EMR or even Epic Anywhere or the Pop Health one for Cerner. They're on their own thing and they're separate. And so they need a way to be able to refer into these systems. We see with the way we're working, it prevents leakage for the hospital systems, better referrals back to the hospital. Specialists can be made accessible to the disparate community from these academic centers. And then once again, you're enhancing this authorization process with the plan providers. Next slide. So we did talk a lot about medical, and I did hear a little, I believe, behavioral health. But what we've been seeing with eConsult and where it's going, we do call it the convergence of disciplines, because we are seeing medical, behavioral, and social all combined. We're seeing interesting scenarios where we have a psychiatrist who's actually managing patients because they're not comfortable going to a PCP. So they're using eConsult to speak with the PCP about certain things. We're using eConsult in LA with LA Care to do behavioral health. We do assessments on the upfront with it, and then we direct through an algorithm whether they need video chat, a face-to-face, or co-management right in the medical home. We're doing social, where we're actually referring through these family resource type centers for abuse, food insecurity, housing insecurity, because you can do a referral or you can do a specialty visit for somebody, but if they're diabetic and they have no ability to work out, they need to also socially be referred somewhere so they can actually be taught some exercise techniques and what would work within their community. So all these things are starting to converge, and eConsult doesn't have to just be singularly medical. And then next slide. So Mitch Katz was the leader of DHS in LA, and now he's in New York, but I think he put it really well. The system is a win-win for DHS. For patients, it means better access. For PCPs, rapid direct communication with the specialist on the best way to treat difficult problems. And for the specialists, seeing the patients for whom they can add the most value. I really love that last statement for the specialist, because that is the point. The specialist is adding value at the point of care in an immediate fashion. And so that's it for my presentation. Thank you.
Thank you so much, Chris. I think Vicente has been monitoring questions that are coming in through the chat. We have a few minutes for those.
Yes. So one question is, you offer an incentive payment to your PCPs during the first year, but after the first year, what percentage of PCPs continue using the platform without the incentive payments? And for those who don't know what PCP is primary care providers.
We were lucky in 90% of our implementations. It was required. So they were all using it after the incentive piece, but in that other 10%, you did see a fall off. And I would say if it was 100 primary care physicians, you would see a 25 to 35% fall off once they didn't receive the $20 stipend to do it. And those were a lot of volunteer solutions in a situation where even the specialists were volunteering and PCPs just had no access for these patients. So yeah, you do see fall off without the incentive.
Thank you, Chris. Another question that came in, much of the larger healthcare systems are, there's a system involved where providers have to toe to the line. Do providers have independence in these healthcare systems to eConsults at their own discretion?
So I'm going to refer to Inland Empire and DHS. So they have to use eConsult in order to do a face-to-face referral. As far as how they ask the questions, what specialty they want to pick, and even building a relationship, we have the ability to pick specialists that you are more comfortable with. It's not all specialists are the same. You do have a little leeway in that. But the mandatory system, you can't do a referral anymore because in all those situations, they're always, I hate to say it, but throwing the patient over the wall to the specialist and let them deal with it. And in these Medicaid plans that we're working with now, you have to communicate on the patient before you do anything. And so I fully believe in that process. Hopefully I answered that question.
Awesome. Mandy, I know we got one more minute left, but one question I wanted to ask was, did you have to overcome any privacy laws with or challenges during this process? Because you do interact with multiple states.
No, we're HIPAA compliant, SOC 2, we're doing our high trust certification. It usually makes every group very comfortable with what we're doing. So, you just go through the security assessment. We literally have 10 million patients, Medicaid patients within our system. And so we've been approved by multiple states, multiple counties, and multiple health plans to manage this data. It is a process. It's not easy, but we've done it. It's just go through and answer everything, be buttoned up.
All right, that's all the questions that we have in the chat room. I'll let Mandy take it over.
Perfect. Thank you so much for speakers today, for lending a national perspective, for setting the tone for the rest of our series. Our next event is next Wednesday, August 26th at 12 p.m. We'll be discussing Colorado more in depth from different perspectives, and all of these are being recorded and will be posted on the Aurora Health Alliance YouTube channel. We'll send those out to meeting registrants and participants. Thank you all.